Okay, today we're talking about renal TB. Renal TB occurs secondary to pulmonary TB or lymphatic TB. Okay, then usually males are more commonly affected and the age is around 20 to 40 years. Infection is always metagenous and mostly unilateral. Okay, what is the pathology of these tubercular lesions in renal TB? First, due to tubercular infection in the renal parenchyma, there will be formation of tubercles. Okay, just like everywhere else. And these tubercles they join or they coalesce to form coalesce, and finally they ulcerate. Okay, this form of the kidney is known as ulcerative form. Okay, next, these the same tubercles they may caseate, they undergo caseous necrosis, and due to that the parenchyma they rupture and they rupture over the renal papilla. They and due to the rupture there will be communication from the parenchyma to the pelvis. Okay, this is known as ulcer of cavernous form. Some of them they heal with calcification, if at all healing occurs. So there will be formation of pseudocalculi. Okay. Next, there is something known as tubercular adrenocrosis. Like why tubercular adrenocrosis occurs? It is due to tubercular stricture at the LV ureter junction. Since there is stricture, there will be obstruction of the renal flow, and patient will develop hydronephrosis. Okay. Next, if opening of one of the calyces gets fibrosed, it will lead to narrowing of the lumen of the calyx. Okay, so that calyx will get swollen due to accumulation of the what we call the filtered material of urine. Okay, and it will lead to formation of hydrocalyx. Due to this, the other normal calyx which are there will also get distorted due to the erythrocalyx formation. Okay, next there is something known as cortical abscess formation in the cortex. Okay, and this abscess it ruptures into perinephric space. Perinephric means wet, and it will lead to tubercular perinephric abscess. See here, you can see the abscess. Okay, like renal cortex will have abscess, and it will transfer to the perinephric area. Okay, and here abscess is formed outside the kidney. That is known as perinephric abscess. Okay. Next is known as something known as tubercular pyelonephrosis. It is also known as caseous putty or cement kidney. Okay. Here what? The name itself is tubercular pyelonephrosis. Due to the infection, the entire kidney will be converted into a bag of pus. Okay. What will it contain? Obviously, it will contain tubercular caseous material. Okay. Since it is converted into a bag of pus, then like since the kidney is no longer functioning at this stage, so what it does, it undergoes a state known as autonephrectomy. Okay, it means like it's as if the kidney is no longer functioning and the kidney is already destroyed. It means the kidney is as if removed from the patient, but the body itself is doing it. Body is itself getting cut off from the other systems and that is known as autonephrectomy. We are not doing it. The body itself is doing it. How to understand what I'm saying? This is known as autonephrectomy. Like why it is known as putty or cement kidney means when it undergoes, calcification, like I said no, like if the tubercle or ulcerations they heal, they undergo calcification. If the entire kidney like that starts to heal, it will be resembling like, see, if a kidney wall is calcified, that means it will resemble like a cement, hard cement. If you see, that is putty or cement kidney. Okay. First picture. Okay. Now this is like, see the earliest ulceration. You can see some holes here. Yes, see, these are earliest is in the calyx. Renal parenchyma, which will later connected the calyx and the collecting system of the kidney. Okay. Mm. This is what we call as hydrocalyx. See, one calyx is severely dilated. Due to that, even the other calyx will get distorted due to this very large calyx. Putty kidney, see here. You can see it become like some, uniform mass part, which is more what we call opaque than normal kidney. You can see that through this X-ray. And putty kidney autonephrectomy. If the kidney undergoes autonephrectomy. If you see the specimen, it will look like this. Look like this. See, like just like a cement, small cement. If it hardens, it looks like that. Okay. Next, finally, due to all that, if the pus and all will gradually subside, the kidney becomes contracted. Okay. Undergoes fibrosis and gets contracted and shrinks in size. So small, contracted, functionless kidney. Finally, due to all the above conditions. Okay. If the patient has something, miliary tuberculosis, means miliary tubercles are formed, then multiple small tubercles will be spread uniformly through the kidney. Okay, this is not that important, but yeah, just putting it over there. Coming to clinical features. What are the clinical features in this condition? Frequency of micturition is one of the earliest symptoms. Okay. Why? Like there is tubular inflammation, due to the infection, there will be tubular inflammation. This affects the concentrating ability of the kidney. Okay. Therefore, it will result in polyuria. Simple. Okay. That's why there is increased frequency of micturition. Then, there is something known as abacterial acid pyuria. Urea. Okay. What is it? The name itself says abacterial. The urine does not contain any bacteria. Okay. And acid. The urine is slightly more acidic than normal. Okay. And it will be pale or yellow in color. Okay. This is what we call as bacterial acid pyuria. Why pale yellow color? Due to pyuria. Due to pus. Okay. So the name is self-explanatory. A bacterial acid pyuria. Next. Hematuria occurs. Like it may or may not occur. Okay. Next. Like typical TB symptoms like evening rise of temperature, then loss of appetite, loss of weight. These are the TB symptoms. These are the symptoms. Which also will occur. Okay, one important feature in TB is lymph node involved. So pulmonary or renal lymph node involvement may be found out. Okay, it can be seen. If it all is present, it will also plus or minus. Okay. So these are the clinical features. Main are two things: increasing frequency of maturation in evacuated acid per urea. These two you should remember. Next, coming to investigations. What are the investigations? Obviously, we have to go for acid fast bacilli culture. Sorry, not acid fast culture specimen. Sorry, acid fast culture. Acid fast bacilli should set in a microscopy. We do it by Z staining. Yeah, no, Z staining. No, if we are understanding, so we can see the tubercle bacilli. And culture can be done to LJ media. Okay, this is the same for all TB, you know, TB liver or any part of system. You do this acid fast bacilli culture. Okay. Next, coming to renal specific renal investigation, cystoscopy. What is the earliest finding cystoscopy? Is the parallel around urinary cortex. Okay. Hmm. Why there is like extensive periureteric fibrosis? Okay. Due to that, ureter will become thickened, shortened, and straight. Okay. This ureter will become thickened, shortened, and straight. And due to that, it does not contract. Like when the bladder contracts, it does not contract, and the orifice is not closed. This can lead to like when the bladder will contract, it doesn't contract. Uh, so what will happen? Such thickened, shortened, straight kidney is known as goal pole ureter. Okay, and due to that, thickened, shortened, straight ureter, when bladder is contracting, so ureter will not contract. What will lead to reflux of urine will occur. Okay, reflex of urine will occur due to this. Okay, and obviously, if urine gets uncorrected, it will damage the renal parenchyma and renal kidney. Okay, that is that. Now, this is regarding bladder. Now, urinary bladder. If the TB organism affects the urinary bladder, it will cause extensive fibrosis. Okay, extensive fibrosis means what? We normally like bladder will be comparatively size will be shrunk compared to normal. Okay, what? So if the size is shrunk, what will happen? There is reduced capacity of collection of urine. Okay, and it will appear as if the urine bladder itself is contracted when we see it. That's why it is known as contracted urinary bladder. So this contracted urinary bladder is known as, there is a name given to it, known as thimble bladder. Okay, or systolic bladder, because in systolic conditions, in any part systolic condition, everything appears contracted. That's a systolic bladder. Okay. Next, this is one condition in urinary bladder, and this is to cystoscopy. The third investigation is intravenous pyrogram. What we see through this earliest sign in this is earliest sign is moth-eaten calyx. Okay, I'll show the picture. Okay, see. Yeah, classification is service only. Moth-eaten appearance. You can see in this, if a moth eats some leaves of a twig, it will appear like this. Some parts will go missing. Similarly here, if you can see very clearly, it's not like very visible, but still, this part is gone. Here it is gone. Here some part is gone. Like, it appears as if the calyx is eaten by moth. That's why its appearance is known as moth-eaten appearance. Okay. Then we can also see through IVP, we can also see single bladder. Also we can see. Next, but the investigation of choice is contrast enhanced CT. Okay, contrast enhanced CT of it. It will give you all the size, the exact area that is involved, whether it was a whole kidney or ureter, it can give you detailed information to CT. Okay, that's why it is the investigation of choice. Now coming to treatment. What are the treatment modalities? First, in early cases, we can do conservative management. They continue giving anti-TB drugs and what we continue giving the anti-TB drugs. That is the conservative management. Okay. Next, nephroureterectomy. Okay. Okay. Means nephro and ureter both are removed. When what are the conditions? Obviously, when the kidney is non-functioning. Next, there is something known as Henle or Handling renal cavernostomy. In this, what they do, they incise the capsule, they go to the renal parenchyma, they go into the calyces, and they will drain the pus. They will incise the calyces and they drain the pus, and they again suture the calyces back and rest of the parenchyma capsule will be left at it for healing. So they will suture back the calyx and surgery is complete. This procedure is done just to remove the pus. Okay, drain the pus. This is procedure known as Henle renal cavernostomy. Ostomy means incision. Okay, for drainage of pus. Next, treatment of thimble bladder. I told you thimble bladder, contracted urinary bladder. What is the treatment? Heliosoplasty. Okay, what is this heliosoplasty? I will show you the picture. See here. Okay. In this 10 to 15 centimeter of ideal loop. This is the ideal loop. What is done? It is isolated along with blood vessels. Okay. And the area of fibrosis like where the urinary bladder is fibrous. For example, you take the example that this is the area of the urinary bladder that is fibrous. Okay, they will remove it. They will remove the fibrous part of the bladder and they insert this ideal loop. Okay, and they suture it. Suture with a healthy urinary bladder tissue. And this condition is known as, this procedure is known as ileocystoplasty. They were taking the ileal loop and we are inserting it into the bladder, suturing it with the bladder tissue. It is known as ileocystoplasty. That's it. Okay. Why is done? Obviously, like the capacity of the bladder is decreased due to fibrosis. So this is done to increase the capacity of bladder. Okay. So these are treatment modalities. There is something known as, just remember, it is not that important. Body flap for uretary stricture. Okay, if there is a uretary stricture, there is something known as a body flap. Okay, that operation is known as body flap for uretary stricture. Okay, so these are the treatment modalities. What is the first thing? Conservative management, giving anti-TB drugs. Okay. Next, nephroureterectomy. When it's done, when the kidney is non-functioning. And the renal cavanostomy. We will cut the renal calyx and drain the pus. Then, single bladder. For single bladder, treatment is ileocystoplasty. It increases the capacity of the bladder. Next, body flap of for uretary stricture. Here, what they do, like, this is the structural diagram. Imagine this is the urinary bladder, this is the ureter, and this part is fibrous. Okay. What they do is simple. They will take the healthy urinary bladder tissue only, flap of urinary bladder tissue, and they suture it here. Okay. Healthy urinary bladder tissue is sutured with the fibrous ureter. So what will then healthy? The ureter will be now functioning normally. And they will suture this together. The cutout part, they suture this together. Okay. This is known as body flap for uretary stricture.